Good afternoon, everyone. My name is Rochelle West Marshall, and I am the Principal Deputy Director of HHS's Office on Women's Health. Thank you all for joining us today for the 2023 National Women's Blood Pressure Awareness Week Virtual Summit. OWH established this week-long observance in 2020 to highlight the importance of blood pressure control and heart health for women and educate on actionable strategies women of all ages can take to prevent or manage high blood pressure. Over 60 million, or 44% of women in the United States, are living with heart disease. Heart disease is the leading cause of death for women in the U.S. and disproportionately affects minority populations, most notably non-Hispanic Black women, who experience the highest prevalence of heart disease compared to any other group. Additionally, individuals living in rural areas, those with disabilities, and those of socioeconomic status are disproportionately affected by heart disease. High blood pressure or hypertension is one of the major risk factors associated with heart disease. Over 56 million women in the U.S. have high blood pressure, which includes 1 in 5 women of reproductive age. 6 to 8% of pregnant women aged 20 to 44 experience high blood pressure during pregnancy. Although high blood pressure affects nearly half of women in the U.S., it is often undiagnosed and difficult to manage, with only 1 in 4 people in the U.S. having their high blood pressure under control. To address these high rates of high blood pressure and associated heart disease in women, this year's National Women's Blood Pressure Awareness Week theme is called Getting to the Heart of It All. This theme brings awareness to the many contributing factors that impact hypertension and heart health and what women can do to manage them. In addition to individual heart-healthy behaviors like physical activity and proper nutrition, this week's daily themes highlight heart disease disparities that exist for underserved populations and the need for health equity initiatives, hypertension considerations for pregnant and peripartum women, the impact of mental health on hypertension, community heart health initiatives, and rapid response techniques to provide life-saving care. Throughout today's discussions, our panelists will take a deep dive into these topics to highlight innovative approaches to hypertension management and treatment to support women's heart health. We will hear from subject matter experts in the field, some of OWH's self-measured blood pressure program champions, and our Phase 2 awardees of the HHS Hypertension Innovator Award competition. Heart health and hypertension prevention and control remains a top priority for the Office on Women's Health. We look forward to engaging in meaningful conversations with you all today and discussing ways we can collaborate with women of all ages. Thank you again for being here with us today. And with that, I will turn it over to our first panel titled Community Initiatives to Address Hypertension in Women.
Thank you so much, Rochelle, and thank you all again, everyone that's joined us today. We're super excited to kick off the summit with our first panel. Today we are joined by hopefully 3 panelists who will, we're still waiting on one person to join us having some technical issues, who will be sharing meaningful work they have been doing in their communities to support hypertension control and heart health. So we're joined by Elaine Johannes of Kansas State Research Extension, Susan Hendricks of the Charlie E. and Minnie P. Hendricks Foundation for Chronic Illness, and Sharon Lofton from No Salt BP. I'd like to start by asking each panelist to share a little bit about their organization and the community initiatives that they've been leading to improve hypertension control. So we will go ahead and start with Elaine. I know we have some slides that we'll pull up here for you in a moment.
Thank you, Danielle, and thank you to everyone in the National Office of Women's Health. It's a privilege, it's an honor to join you. I am in my office. I'm here in Manhattan, Kansas. We're called the Little Apple, and I'm an academic person. I'm in a university setting. My designation is Kansas Health Foundation Distinguished Professor in Community Health. And yes, I advise students and I teach, but most importantly, I have the privilege of working with a system that's called cooperative extension. And that's really where our heart health and hypertension prevention work resides. So I'm going to take a few moments and explain how we address heart health and hypertension through HAP, the Hypertension Awareness and Prevention Program. And on this slide, you will see my email. I welcome emails. I would be more than happy to share our materials, the resources we have. I may say also, not only are we a member of the Office of Women's Health Self-Monitoring Blood Pressure Initiative, but we are also a champion in Healthy People 2030. So we have that designation as the cooperative extension system in our state. So let's go to the next slide, and I will explain a little bit about what is the extension system. I think I'm the only panelist today that is from a university, and more importantly, a university that is a land grant. The land grant university systems are across the United States. They were initiated more than 100 some odd years ago, and you'll see that my home is Kansas State University, which is the first land grant university in the United States. Now, for our friends who are from Michigan State, we could talk about who was the first land grant that was operating. We like to say K-State was the first, but Michigan Staters, we could visit about that. But part of the land grant mission is to take research and the knowledge that's being generated through our universities in the United States and translate that so it can improve the lives and the well-being of families, people, and communities across the whole world. So the extension systems that are in your states are the translators of research, and we are the appliers of research, and then we take that understanding of practice back to the universities, back to our federal agencies and our collaborators so research can continue. I may say that we are not the only land grant. We have the 1890 historically Black universities and colleges. They are also land grants, and we welcome them on the webinar today. Our nearest land grant from my state is Lincoln University in Missouri. And then in 1994, we welcomed all of the American Indian colleges and universities to the land grant system. And my closest 1994 American Indian College is at Haskell. And Haskell Indian Nations University is governed by more than 150 nations. So I want to, again, acknowledge our sister land grants that are on the webinar today, and also encourage them to become part of this federal initiative. So with the land grant designation comes a cadre of educators, researchers, and practitioners that are located in every county of the United States. We have extension agents. That's who we call our professionals in the field, who translate the research. I have the privilege of supporting them with a team, and we've translated some of the good practice and research of how to help women and anyone monitor their blood pressure for heart health. So let's get into it. Danielle, the next slide. So our initiative in this state is called HAP, and it is the Hypertension Awareness Prevention Program. And in 2021, we became aware of the Healthy Heart Ambassador initiative that most departments of health were implementing across the United States. And then we also became aware of our numbers here in Kansas. that we do not meet the Healthy People 2030 objective for having people having hypertension under control. Kansas is one of those states that Rochelle talked about that we aren't meeting the mark. So we also knew from our own workforce in extension, which is comprised of women primarily, that our hypertension rates were increasing. Not only increasing, but the number of our workforce that were having medications to manage it, but also not having a lot of success given the fact that they weren't monitoring their own blood pressure. So we implemented a pilot, which is called HAP. And in 2022, we started working with our Department of Health and Environment and also with an industry group, which is called Kansas Business Group for Health, which is comprised of the medical societies in our state. And we trained our county and local extension professionals, who we call agents, in being healthy heart ambassadors. So everybody was trained to do HHA, which is very good skill and practice on how do you take a blood pressure that's meaningful. We equipped everybody with blood pressure cuffs that were of the validated list. And we trained people on cuffs, wrist and arm, on how to take a blood pressure accurately. And we infused that with the American Heart Association's check, change, and control initiatives. So we did a mashup, I guess you'd say, of how can we do individual client coaching in the offices of our extension agents, and then also doing community education. So bullet point number 2 describes how we actually did that. We kicked off on the American Heart Month, February of last year. We implemented the initiative for 4 months per the direction and the evidence base of the Healthy Heart Ambassador program. We infused some really excellent health style and nutrition education every month with our client groups. And then we did some stress management. We used Compact, which was highlighted in one of the National Office of Women's Health webinars, which was early in 2021. So we utilized Compact with all of our agents and clientele. And then we also did a community awareness campaign. We developed materials based upon rural and frontier, as well as urban and metro pilot sites, where the community could start becoming aware that hypertension is a worry, is a concern, and is a pathway, per se, to other diseases and chronic conditions. We also have a high diabetes rate in our state. So again, that awareness of hypertension connected to other chronic conditions was important. And then bullet point number 3, we conducted the 4-month initiative per what Healthy Heart Ambassador program requires in cooperations with our community health clinics, which are our FQHCs, community health workers. We have a very strong workforce in community health workers in the state, with businesses, with SHIC, which is the Senior Health Insurance Counseling efforts that extension does do in this state and most extension systems. And we worked with coalitions. Those coalitions are funded much of the time with community foundations. So we were very boots on the ground, working really with people that had not been aware that they needed to be managing their hypertension, checking their medication, and in being empowered. So the next slide. So this is where we were, and this is where we're going. So this is a map of Kansas. This is the extension map. So the purple parts of the map indicate that's a regional administrative function for extension. In this state, we have county offices and we have regional offices. I would encourage you to check in your state where your extension offices are and maybe start collaborating. And then the picture right adjacent to that is our HAP pilot team. These are our county local extension educators, agents, who implemented HAP very successfully. You'll see these red little points. Those are where their offices have been located, where they are. And we successfully conducted the HAP initiative, and we measured outcome related to intent to have regular blood pressure checks, the number of our clients who actually went to their physician, went to their healthcare provider and advocated for better checkups, more frequent monitoring of their medications, and then also had some diet changes. We had one of our county groups who not only had local client coaching in the extension offices, but would meet every month for nutrition education. That group, which was 15 different people, started to share recipes, and then they would start to cook. And then it became a really wonderful social support group, which is continuing. And so this pilot test is continuing. That's the bottom sentence there of the slide that says, thanks to our success of working with our Department of Health, with our medical societies and extension, we're now receiving the CDC's National Cardiovascular Health funding to continue and expand. So those are my slides. I am so glad to be able to share what we're doing in Kansas, and I'll be glad to answer any questions that people have. Thank you.
Thank you so much, Elaine, for that great overview and the meaningful work, and the plug for folks to look for their state extension office. It's a really great resource. So at this point, I will turn it over to Susan Hendricks to talk about her community initiative.
Good afternoon, everyone, and thank you for inviting the foundation to tell you a little bit about what we're doing in the communities here in Detroit. I'm Susan Hendricks. I am the founder of the Charlie E. and Minnie P. Hendricks Foundation for Chronic Illness Awareness. My background and my degrees are in the field of health and science. We are a nonprofit that focuses on educating those in underserved communities about chronic illnesses via our annual Giving Back to the Community events. Our focus is on underserved communities where chronic illness is at a high proportion. These communities lack necessary resources. We know that hypertension is more common in African American individuals than in those of other racial ethnic groups in the United States. Hypertension is a major risk factor for heart disease, stroke, and other serious illnesses. Our foundation established Know Your Numbers, a health promotions program. Know Your Numbers is a program that promotes health, wellness among residents in the city of Highland Park, Michigan, and Detroit. It is a series of workshops that will focus on topics such as taking one's blood pressure the correct way, how to log readings, healthy communication with his or her healthcare providers, nutrition, and most importantly, physical activity. This program is designed to reduce the effects of high blood pressure and curtail common secondary underlying conditions within underserved communities. Through our annual events of Giving Back to the Community, where we provide food, personal care items, and a listening ear. Residents, this gives us the opportunity to get information from residents within this community, such as their health status. Is there a history of hypertension within the family? Does the individual have hypertension? We get the individual's primary care physician's demographics. the family history. Do they know the signs of having hypertension? If the individual has hypertension, how often is the blood pressure readings taken? And are the readings being logged in and being shared with the physician? Is the individual adhering to their medication regimen? And what type of physical activity is being performed? And are they maintaining a healthy diet? We have been in existence since 2019, and we have been going strong. Once again, I would like to thank OWH for having us on, and to let you guys know we are also proud partners of SMBP program.
Thank you so much, Susan, for giving us that overview of your meaningful work. I wanted to dive into more of a discussion with both of you and pose the question for folks on the call today who may be wanting to invoke similar initiatives in their own communities or are trying to make partnerships with local community-based organizations, such as the foundation, or work with their local extension office. What lessons have you learned from this community work that could inform other folks who are trying to do work in the area of hypertension and heart health?
Elaine, would you like to go?
May I begin?
Yeah.
Susan, just what you said is what we discovered, and I think this is a lesson learned. Susan, I wrote down what you said: log what your numbers are and share them. Mm-hmm. Yes, ma'am. I was surprised at the number of people, our clientele, which we ended up with 72. Now, 72 individuals who actually did participate for 4 months, did client coaching, came to the sessions, logged their numbers, and told us what the results were. But I was amazed, lesson learned, that the numbers of clinicians and providers don't have time to ask their patients and clients what your numbers are. And nor do the nurses, the practitioners, the providers have time to teach people how to take their blood pressure. And Susan, that was a lesson learned for us. Log it and share it. And that's what you said. So I would say, Danielle, one of the lessons learned, there are many and we could talk about them, but just the fact that, this is truly team. It's the client, it's the patient, and the provider, and having somebody who's a go-between, be it a county extension office, an agent, a CHW, Susan's team, someone who can be the connector between the person in need and the provider.
Now, for us, in this day and time, we found that there still exists a mistrust within the underserved communities regarding the medical professional. There is a belief that from a health consumer's standpoint, that a physician's care is based upon one's zip code and ability to pay. We must not forget that there exists a lack of physicians who do not resemble these underserved communities. We must gain trust with individuals who reside in underserved communities. It is important that the medical professional must learn how to talk to them and not at them. So that mistrust between medical professionals in this day and time still exists. It's not that they don't want to seek the care. They don't get the same respect back as they give to the medical professional. And that's one of the biggest ones, especially in communities of color, the mistrust of the medical profession.
Yeah, absolutely. And that actually dovetails really nicely into my next question is, what challenges or what are the major obstacles that you all have experienced in this work? In, even taking that a step further, how have you worked to mitigate that, whether that be with additional resources, with partnering with community organizations or communities themselves, sort of, again, speaking to folks on the call who may be wanting to do similar types of work or maybe running into the same barriers that you all have?
Susan, do you want to go first on this one?
All righty, Elaine. Through our endeavors, we have found out that there exist those who do not know how to take blood pressure readings themselves. There are those who cannot afford blood pressure monitoring devices. There exist those who must make a choice between purchasing medication or purchasing food or paying a bill. But most importantly, there exist those who are too afraid to have that open dialogue with their physician. They allow that white coat jacket to intimidate them. So what we have done, we have compiled a list of questions, and we give that to them, and we tell them, don't sit in silence. That is your worst enemy. There is no such thing as a stupid question. Ask. This is your health. You have to advocate on behalf of yourself. And those have been the barriers and challenges within these underserved communities.
I think Susan and I are of the same cloth. We see similar things, but in a different perspective of where we are in the United States. I will also echo the barrier of access to just the devices. That's of concern. If any of us are doing this work, we know that there can be some reimbursement based upon your state's Medicaid funding, but Medicare does not consider it a reimbursable yet. So I think advocate for that. Blood pressure cuffs are expensive, especially those that are of the quality that people need. And so we did find internal grant money, and we did have the collaboration with the Kansas Business Group for Health, which are our medical societies, who contributed money. So we did purchase valid blood pressure cuffs for every client and every county local extension agent who was initiating HAP. We did the arm cuff and we did the wristband. So just to let people know that we were aware that we needed to provide that tool so clients could learn and practice and feel comfortable with taking their own measures, and that they could actually teach their people at home. That was the other thing that we found initially a barrier, but we got, I think, through that. Some people were hesitant to take their blood pressures when they were at home. They thought they needed to hide it. I think there was still a factor of embarrassment or shame that hypertension was their fault. So again, teaching that you could take your blood pressure at home in front of a partner, a spouse, a child, your cat or dog, it is a behavior that can be a habit. The other barrier was just what Susan had talked about, was communicating to the provider. We are a primarily rural state. However, we had pilots up in Wyandotte County, which is a primarily Kansas City metro, inner city, very diverse community. We also had Wichita, which is also metro, but then we had very rural areas. So we learned about how to empower clients of all sorts to go into their provider and advocate for self. I love what Susan said. I've written a note about the questions that her group have come up with. We also had our clients, when they went to see their county extension agent, to do blood pressure checks in the office as part of the Healthy Heart Ambassador program. We had clients who were trained in the motivational interviewing technique. That technique allowed the county extension professional to ask a question and allowed then that client to practice questions back to them. So the role play or interviewing technique was tried in the county extension office, which was less intimidating than when that client or patient went to the provider. So what your team have discovered, so did we, this whole concern about when I go to see a doctor, my blood pressure goes up because I'm afraid, I'm worried, and then I don't ask the questions that I need to. So practice is important. The other thing that I would say for our rural states logged in today, we did not know pharmacies would start to close. So when we began HAP, it was at the end of 2021, we implemented in 2022. We just finished actually all the pilots just earlier this year. But due to the pandemic, economics, and now we're having water issues in this state that are affecting how vibrant communities are. Local pharmacies started to close. Mm-hmm. And so when we had clients who were not able to get their prescriptions except through the post mail, or they'd have to drive 45 minutes to go to the local bigger community to replenish and refill prescriptions. So that is not unique to hypertension. But I think any of our collaborators or people on the Zoom today, if we are doing rural frontier work, be prepared for this depletion of providers of all sorts, including the pharmacies that are local and the pharmacies who know clients and know what they should be taking or not. And that's something that we put on our list for this year, for the next year, of what we need to do to be advocates for providers now.
I would just like to piggyback on something Elaine said. The foundation has purchased over 40 blood pressure monitors through the assistance of one of my colleagues who is a nurse. We have taught individuals how to take their blood pressure and how to log the results to share with their physician. We have discussed the importance of decreasing salt intake and the importance of a healthy diet. We have assisted those who live in these communities and are on limited income purchase hypertension medication. We don't give them the money. We call the pharmacy ourselves. When an individual calls us and say, can you help us this month with medication, hypertension medication? We get the pharmacy's name, telephone number, and we pay out of pocket ourselves when our funding is minimum. So I just wanted to piggyback on that, and that we have urged and talked to physicians, primary care physicians, along with cardiologists, about joining us in this endeavor to fight hypertension and to join OWH SMBP program.
Thank you both so much for that dialogue. And there's a couple of questions from attendees that relate to things that you all just said. So first and foremost, Susan, there's a couple of folks asking, you mentioned some questions that you provide folks to bring to their provider's office and ask them. Are those publicly available, or would you mind sharing what some of those questions are?
The questions may be, as I tell those within the community, just like that doctor sits down when you initially go to the doctor's office and he begins taking his assessment of you, now is your turn to ask that physician questions. What should my normal blood pressure range be? What if I get dizzy? What is it that you want me to do? Don't be ashamed to say, I don't have the funds. Do you have samples of that medication? But I will leave my email link in the chat box, and if they want to, they can contact me and I will provide that information. That is just some of the questions.
Much appreciated. Yeah. And we'll make sure to share out your contact information as well. And there's a lot of people in the chat that are just saying that that's something that they run into is providers will just take up blood pressure and say, oh, you're good or you're normal without an explanation of what those numbers are, where they are in terms of risk, and having, the importance of folks knowing what their average is so that when they go to providers, over time, they can understand where their blood pressure is. So I really appreciate that input.
And physicians should not forget they're talking to lay people. Most people won't understand medical terminology or medical language. So that's where the physician comes in and make that individual feel comfortable and say, well, let me tell you this way where you could better understand. But most physicians don't have the time to sit with individuals and do that because of the patient load.
Yeah, absolutely.
May I contribute to this chain of thought? Because it's really important. Because when we began thinking about hypertension and why hypertension is relatively higher than the national average in this state, I think I shared with this group, I was surprised, a lesson learned that again, the providers care, but they really don't have time to teach. Mm-hmm. So having a teacher that is from the community who has lived experience, Susan, that's what you're speaking to, is important. And so we not only found that the Healthy Heart Ambassador skill set and using that with the county extension office as the client comes in twice a month to do their coaching. In that coaching relationship in the office, the agent then can become the coach of how can you ask your doctor about your meds? How can you communicate and actually slow the doctor down a bit so you can get your questions at least asked? But then we also have, I had mentioned before, we also have a good building group of healthcare workers. So the community health worker, the CHW, who's located out in community, is that connector between the person with lived experience, the county extension agent who's the teacher, and then that community health worker who could kind of be that instigator of an opportunity. The person who makes sure that the client gets to the appointment, the transportation, the person who says, now you've got this prescription from the doctor, how are you going to fill it? Yeah. So for those that have access to community health workers, CHWs, that CHW is to be that connector. And it does require people who have lived experience, who have an understanding of why is it that we're stressed when we can't get to childcare to pick my child up, and then I can't get to the pharmacy that's closed, so I do think there's opportunity to fill the gap and not always assume that the provider will answer everything or be the end story for clients who really need help.
Yeah, absolutely. And I'm wondering, Elaine, if you could speak a little bit more. I'm sure every state is different, but the ways that people can go about maybe connecting or identifying CHWs in their community, and even, I guess, more broadly than that, additional resources and partner organizations that can help. support community members?
Thank you for asking that. I usually try to think systems, and so that's what you're asking about. I would first start to think about who in my state office of health, my Department of Health, deals with chronic disease. And who that person or that unit or that bureau is. They probably have access to a variety of chronic disease prevention programs and grants. For example, CDC, their 2304 chronic disease management grants for hypertension specifically. So first off, start there and find out, well, what's really going on in the state already that is part of evidence-based work and is in alignment with Healthy People 2030 initiative. Then contact your local land grant. Missouri, Michigan State, Colorado State, Virginia Tech, Texas A&M, University of Hawaii. So your land grant, and get on the website and Google extension. You're going to find there's an extension service connected to that, and you'll hopefully find the map of where your professionals are. Now, my designation is community health. You'll find my counterparts, similar kind of work, maybe the title is different, located in extension. And by the nature of how extension works, we communicate and we share. And so if you come into a local extension office and they are not familiar with some of the hypertension work going on in this state, and also North Dakota, we found out, there are the extension people who'd be willing to share. I'd be willing to share our marketing materials, anything we have, and anything that we did that actually mashed together. Healthy Heart Ambassador, the nutrition education that Susan talked about, also our access to community health workers, and then the community engagement and awareness materials. Because not everybody is aware that hypertension is everywhere. It is in our workplaces. It is in our childcare centers. It is a concern in our county government offices. So I would say start at your Department of Health first, see what resources are already in the state, and how can you grab a hold of them.
Thank you very much. Susan, anything to add about partnerships or connections that you'd like to add?
I would have to piggyback off of what Elaine said. Same thing. We think alike, Elaine. Start with your Department of Health to get some resources. And if you can't find any, all you have to do is call the foundation and we will assist you in locating that.
Mm-hmm.
Thank you both.
I would add, I'm going to interrupt because we have an opportunity here to advocate on behalf of our clients. If CMS, Center for Medicaid, Medicare Services at HHS, is entertaining and looking at making it effectively reimbursed through Medicare, meaning the blood pressure cuffs, advocate now, advocate today. I don't think the public comment section is open anymore, but I do think a group as large as this is that says we need to have blood pressure cuffs reimbursed by Medicare. That would help a lot because it would bring people into awareness that this is an important part of my health. And Medicare acknowledges it. So that's an advocacy role that this whole group can have.
Yep. Thank you all. We have about 5 minutes left, so I'm going to ask sort of a wrap-up question. If folks are just getting started in this work, Susan, I believe it was you who mentioned trust with the community earlier. So how do you all go about building trust with the community to then learn their unique needs when it comes to these areas of health? Because we can all, of course, look at the statistics that are provided, at county, state, and national levels, but how do you actually build those partnerships in your communities to understand what the needs are as relates to heart health or chronic disease?
Our foundation is a foundation based on all boots to the ground. We get out in the community and we talk to individuals. We don't talk at them, we talk to them. And that is one of the most important things anyone can do. Respect that other individual, and they will learn to trust you and open up to you. I have individuals calling me now who have food shortages, asking me, can you help us with food this month? And it's no problem. We help, we purchase, and take it to them. But it's an open dialogue, making that individual feel comfortable. And if you're genuine, they can see it. And if you're not, they can really see it and they'll close you off. You have to be genuine and talk to them to get them to open up, to gain that trust.
Susan, you've just said spending time and building relationship.
That's right.
Hypertension is just one of the chronic conditions that sometimes people are shamed around and embarrassed about, let alone they're not aware. So having time to build relationship and being in dialogue and having a similar experience. So you saw the picture of our agents who pilot tested HAP, and now that's that group and bigger now in our state. You saw that they're women of all different ages, but they are not women of different colors yet. Mm-hmm. So we did talk about how do we engage a community that does not look like us and may be suspicious or may be uninformed. Mm-hmm. And so that's the reason why a community health worker is essential. The community health workers in the United States are from community. They have lived experience. They are trained. They are co-trained in our state. We had community health workers trained with our agents in the Healthy Heart Ambassador work. They learn together the skills of how do you take an appropriate blood pressure? How do you do motivational interviewing? So our agents with the community health workers were trained. But it's that community health worker who comes from community. Now, true, our agents and all extension comes from the county and comes from the state, but their experiences may not be aligned to that most vulnerable population, the community. So I think having a community health worker alongside a county or local agent or educator for extension and having open relationship that is built over time. Because we're talking about a chronic disease that isn't just answered in even a 4-month program like ours. It requires time and trust. And Susan, yes, ma'am, that's what you're talking about.
That's the key. That's the key. That's the key to it all.
Mm-hmm. Thank you both so much. I'm going to squeak in one more question, actually, because we've gotten a couple of them. But folks are asking about how to select the proper blood pressure monitor. Do you all have a list that you work off of? How is that conversation had to gear folks in the right direction?
I'm going to blurt out, I think it's www.validatebp. And Danielle, I think you could probably just find that quicker than me, but just Google Validate BP. And that website is current. It is kept up and it gives you not only how to make sure the device is appropriate, but also there are brands. There's a whole variety of bands. There you are. It's in the chat. Now the costs will vary, and that's what we've talked about today. The costs of the cuffs and the costs of the extension, because we have clientele whose arms don't go into a regular size blood pressure cuff. So the costs will vary, and that's the reason why we need to have a way to reimburse those costs or find a provider or a philanthropist or some group who can provide the right cuffs. But there you go, Validate BP.
I just want to put a plug too. We'll be having a speaker later this afternoon that'll touch on that point as well. So if you're interested in it or you submitted that question, feel free to stick around. Well, thank you all so much. We're just at about time here. Any closing thoughts that you all want to add?
I just want to say thank you. And I also want to say, women, take care of yourselves because you take care of the family and the community. So women, we can affect the blood pressure of our males, all different kinds of people in our communities and our families, and the children who are watching us take care of ourselves. We found that ripple effect to be really important.
I would just like to thank you once again for having the foundation on, and also women. We have to stop putting ourselves last. It is stressful out here, I know, but we have to take care of our health. And the knowledge that we learn from taking care of our health, we have an obligation to pass that knowledge along to the next person within the community so that they can keep the ball rolling.
Well said. Thank you both so much. And to the audience, we'll make sure that the contact information in the slides or any information is shared back with you all at the end of the event. But thank you all so much. It was a really great discussion. At this time, yes, absolutely. So at this time, we're going to transition to hear a patient story, which is actually very perfect based on the conversation that you all had. A patient success story from a Women Heart champion, Dawn Blatt. So Women Heart champions are the boots on the ground folks in the fight against heart disease. They are women with heart disease who have been trained to share their stories and important messages about heart health to empower women to take charge of their own heart health. So Maggie and Dawn, over to you all.
Great. Thank you so much, Danielle, and all the excellent presenters from the last panel. It's really such great information to start us off with. My name is Maggie Snyder. I'm a lead public health advisor in the Office on Women's Health in the Office of the Assistant Secretary for Health here at HHS. And I'm so pleased to be here today with Dawn Blatt, who, as Danielle said, is a Woman Heart champion to talk about her story. So thank you, Dawn, for joining us today, helping us ground the NWBPAW Summit in the perspective of people who have experienced hypertension. What can you tell us to start us off about your story?
Well, first, thank you for inviting me and finding me through Women Heart. I've been part of the organization since 2013. My story actually starts as a cardiac event. I had a heart attack at age 46. No family history, no prior signs and symptoms, came from out of the blue. And since 2012, my heart journey has even evolved and changed. A few years back, instead of the initial cause of my heart attack being due to plaque buildup, it was due to something called SCAD, spontaneous coronary artery disease, which affects primarily women, tends to be misdiagnosed. So that diagnosis came to me about 5 or 6 years after my heart attack. But I've been followed by a cardiologist since my heart attack in 2012. But my additional story now, and the addition of blood pressure issues to my story, started this past March. So I had been on blood pressure medication since my heart attack, but my blood pressure has been fine. In March, one night, I just started not feeling right and wasn't sure what it was due to. And the next day, I decided maybe I should take my blood pressure. My head felt woozy. And so I monitored it a few times, and I was getting readings 180s over 110s, 190s, and, it wasn't coming down. I tried resting, relaxing. So when it was probably about 200 over 120s, I told my husband I needed to go to the emergency room to get checked out. I was really concerned I was going to have a stroke. So I went and spent about 5 or 6 hours in the ER. They gave me a low dose of medication and discharged me. My blood pressure was still 170 over 100, which was concerning. I still thought that was kind of too high, but went home, saw my cardiologist, or my cardiologist, actually, he didn't even want to see me at first, said, monitor your blood pressure, see how it is. He didn't even recommend that I continue taking the low dose of medication because it had come down to close to normal, but still wasn't in a normal range. I monitored my BP for a while and decided in July, I had a bunch of readings. I sent a message through a portal to my cardiologist with all my readings and said, my readings are still above what's considered normal, and I'm concerned, and I think I should go back on the blood pressure medication. So he said, okay, and gave me a prescription. But it was my advocating for myself and feeling like I shouldn't have readings of blood pressure that's in the 140s over 90s or even 100 to continue that way, that it wasn't healthy for me.
Yeah, it sounds like you had to do a lot of work to get to a good place.
Yeah, I felt like I needed to advocate for myself, which is something that I have learned to do since my heart attack, and Women Heart has empowered me, and I try to help other women for the same thing. If something's not right, you need to follow up and make sure you're getting the care that you need.
Yeah, and it's barriers to identifying your condition or to accessing care.
I'm sorry, I lost you for a second.
Oh,
what was the
my
question?
apologies.
It's okay.
Maggie, looks like you're having some technical difficulties, so we'll just give her a second. But Dawn,
okay, I wasn't sure if it was on me.
No,
okay.
Definitely, no, you're all good. So there, okay, Maggie, maybe turn off your camera because we can hear you now.
Okay, great.
And then repeat that last question.
Thanks so much, Danielle. My apologies, Dawn. So the question is, were there barriers to identifying your condition or accessing care other than what you've identified so far?
No, I'm fortunate that I do have a home BP cuff, and I've had one since my heart attack in 2012. So I can regulate, I can monitor it to see if there's any trends. I think that my cardiologist, if I call to make an appointment, he's receptive. If I call to get information or need, like I said, I advocated for the blood pressure medicine, and so he responded with a prescription. So I feel fortunate that I didn't have any barriers.
That's wonderful. Here.
I think I'm losing Maggie again.
One second, I'm trying to get her back real quick. One moment, Dawn, apologies.
No worries.
Okay, can you see that question in the chat, Dawn? Maybe that's easier. And I apologize to everyone for the technical difficulties.
I do see your question. So processes that help me, I think for me it was being able to monitor my blood pressure, following through, making sure, because, when it's a little high, you don't feel any symptoms. When it was really high, that's when I did know that my blood pressure was too high and needed to go to the emergency room. But let me go back to your question one more time. Sorry. My cardiologist prescribed the medication for me, so that was helpful as well. Something that has happened more recently within the past couple of weeks is I also received a new vascular diagnosis. I had seen a new cardiologist out at the Mayo Clinic just for an evaluation and was diagnosed with something called FMD, fibromuscular dysplasia. And so the treatment for that, there is no set treatment, but the way to monitor it and best prevent any other problems is through blood pressure. And so I need to keep my blood pressure actually even lower than normal. So that was something new that, again, makes it really important to follow through and make sure my blood pressure stays low with either the medications I'm on now, or to reach out to the cardiologist if the current meds are not working.
Yeah, it sounds like it's a kind of an iterative process with lots of communication needed between you and your medical providers.
Yeah, and finding the right cardiologist, I think, for me is important. Finding somebody who understands my diagnoses and is willing to work along with me to manage it.
Absolutely. Yeah, finding the right people to support.
Mm-hmm.
Now, are there challenges now that make it difficult to control your hypertension?
No, I think I need to follow good health practices. So I need to make sure I take my medication every day, that I exercise, that I follow a low sodium diet, which I've been doing over time. But it's important to keep up with these things and make sure that I'm doing the right things and taking care of myself, making sure that I follow through.
Maggie, you cut out again a little bit. We could just give it a breath, and then you usually come back.
Technology is great until it doesn't work.
Absolutely, absolutely. And we know that technology can be useful for keeping your blood pressure under control too. Okay, can you hear me now?
I can.
Yes.
Great. Okay, so you talked about some supports. What are maybe some other supports that contribute to keeping your hypertension under control?
I'm looking to start to practice meditation, and I know I downloaded a couple apps on my phone. Unfortunately, that doesn't lower your blood pressure automatically, but I'm looking to practice daily, starting out with short practice times, and always looking for technology. What can I do that can support, any changes or anything else I can do that will help to monitor? I think that's helpful.
Yeah, absolutely. Yeah, technology, when it works, can be great.
Mm-hmm. Yeah.
And yeah, absolutely. Anything that kind of takes that cognitive burden off of you and puts it on as well. Great. Are there other new or emerging, as we've discussed, that you find helpful in controlling your hypertension?
You cut out a little bit, but I'm thinking you're asking about any new resources? Was that the question? Okay.
Absolutely.
Well, for me, I'm in the process of changing cardiologists, so we'll be starting with somebody new in the near future. So a new person, maybe we'll have some new ideas for resources. I think I have the support of other women through Women Heart. We're an organization that provides peer-to-peer support. So really helpful to connect with other women who are living with heart disease, who are also facing some of those same challenges. So for me, the peer support is really helpful. It started after I had my heart attack and found Women Heart in 2013. So I think that peer-to-peer support for women with any kind of diagnosis is helpful, but I've found kind of my community and my people in that group and can connect with them, and we can, share resources or share, I just found this new app that's really helpful, or, there's a new medication or test out there that could be helpful. So connecting with other people will help to connect me with resources and technology. I'm always looking that can be helpful. This blood pressure diagnosis for me, or high blood pressure, really started back in March. So it's on the newer side for me for looking for more resources.
Absolutely. And we're so glad to get that perspective of someone who is fairly new to this. And then later today, we'll have your fellow Woman Heart champion talk about kind of that perspective of of controlling hypertension for a longer period of time. So it's great to balance out that perspective. So I'll just fit in one final question, if you can hear me okay.
Yes.
As you reflect on your experience, is there anything that you would have done differently or recommend other women do if they're diagnosed with hypertension?
Yeah, well, first, probably for me, if anything, I probably should have gone to the ER when I first started noticing the signs of the high blood pressure. I was fortunate. I didn't have a stroke. Nothing happened. And I went the next day, but what I tell other women is what I need to listen to myself. If, you're experiencing something, you need to go get checked out as soon as you start feeling those symptoms. Don't put it off. For other women, I would also say, monitor your blood pressure, as the women in the prior session spoke about. It's really important for me to just keep an eye on it and monitor it. I don't need to take it 3 times a day, because sometimes if you do it too much, you'll increase your blood pressure. But take it periodically, whether it's once a day, once every few days, following up with the doctor for management. And as I said before, if you're not happy with your current MD, or feel like you're not getting the attention you need, or they're not really hearing you, to find a provider that's really a good match for you. And lastly, something I always think about and tell other women, as the last speaker spoke about, we need to take care of ourselves. So self-care is not selfish. We need to prioritize our health and put ourselves first so that we can, help take care and support others.
Absolutely. Thank you so much, Dawn. That's a great message to end on, taking care of yourself first, amidst all the other competing priorities that women have in their lives.
Yes.
So again, thank you so much, Dawn. Great message. Now we'll transition over, and my colleague, Gage Dalton, will help us with that.
All right. Thank you, Maggie. And thank you, Dawn, for that wonderful perspective on how you were able to successfully control your hypertension. I hope your story empowers others who face this issue in their own lives. We will now move into a short break before our breakout sessions. For the breakout rooms, there are 2 panels that attendees can choose to join. A panel focused on partnering with your community to advance hypertension control, and another panel on hypertension control through behavior change. For those joining us via Zoom, in just a moment, a prompt will pop up on your screen with the 2 options displayed. Please select the panel you would like to join before the panels start, which is slated to be in about 8 minutes at 1:20 p.m. Eastern Time. And those joining us via HHS TV will automatically be joining the panel on partnering with your community to advance hypertension control. And now we will start our break. Please make sure to join us back at 1:20 p.m. Eastern for the next portion of the National Women's Blood Pressure Awareness Week Summit. Thank you.
Produced by the U.S. Department of Health and Human Services.